Welcome to the deep dive. Today we're really getting into the essentials, the stuff you absolutely need to know, especially if you're, working towards those postgraduate orthopedic exams.
Mhm.
Our topic is humeral shaft fractures. And this deep dive, it's based on the fantastic ortho-made simple notes you can find on the website mokyingren.sg.
Yes, Dr. Mok's notes.
Exactly. They're compiled by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, finished his FRCS back in 2022. So the plan is simple. Pull out the critical knowledge from these notes.
The real high-yield stuff.
Precisely. We're talking causes, displacement forces, treatment choices, and crucially, how to handle those tricky radial nerve injuries that often come along with them. Ready to jump in?
Let's do it. It's a vital topic.
Yeah.
These fractures, they're not just about the bone, are they? The nerve, that's often the big player.
Absolutely. And the first thing that really stands out from the notes is just how often you see radial nerve palsy with these. It's not some rare thing.
No, not at all. If you look at the overall numbers, like that 2005 systematic review by Shao, it's sitting around 11.8%.
Okay, about 1 in 8, 1 in 9 cases.
Yeah, roughly. But, and this is important, it really depends on which fracture pattern you're dealing with.
Right, so some are more risky than others.
Definitely. Take the Holstein-Lewis fracture, that classic spiral one down in the distal third. The notes mention studies, like Eckholm's, showing the palsy rate there shoots way up.
How high are we talking?
Up to maybe 22% in those, compared to maybe 8% in other types. Though the fracture shape itself tells you a lot about the nerve risk.
That's a really key point for exam focus, I'd imagine, knowing the high-risk patterns.
For sure.
What about open fractures, if it's open and there's a palsy?
Well, that changes the game significantly. If you've got both, an open fracture and a radial nerve palsy, well, Foster's case series from '93, mentioned in the notes, found something like 64% of those patients.
64%.
Yeah, 64% had the nerve actually cut or trapped right between the bone ends. That tells you straight away you're probably not just looking at a bruise. It might need direct exploration.
Okay, that makes sense. So before we even think about fixing it, we need to understand why it breaks the way it does, those deforming forces.
Exactly. It's all about the muscle pulling on the fragments.
Yeah.
The big one is the pectoralis major. Where does the fracture sit relative to its insertion?
Okay.
If the fracture is distal to the pec insertion, that muscle pulls the top bed, the proximal fragment, inwards towards the chest. Adduction.
Right, because it's pulling on that proximal piece.
Correct. Now, if the fracture is proximal to where the pec attaches, the pec muscle isn't really affecting that proximal fragment's position relative to the distal one. Instead, the deltoid, which attaches higher up, takes over.
And the deltoid pulls outwards, abduction.
Exactly. The deltoid pulls the proximal fragment into abduction. So just knowing the level relative to the pec major helps you predict how it's going to displace.
Simple mechanics, but really useful. Okay, so assessment done, nerve status noted. What about management? Let's start conservative. The Sarmiento brace, how does that actually work?
Yeah, the functional brace, it's quite clever, really. It's not just holding it still like a cast. You've got these shells, front and back, tightened with Velcro. They work partly by just compressing the soft tissues, sure. But the key idea is using the muscles themselves to create hydrostatic pressure, kind of like a hydraulic effect within the soft tissue sleeve, pushing the bone ends together. And there's ligamentotaxis, too, using the tension in the intact soft tissues.
So it needs the patient to be involved, right? Daily tightening, regular checks.
Absolutely. Needs commitment, daily tightening, weekly follow-ups, usually for about 6 to 8 weeks. And it's super important to know when not to use it. The absolute contraindications.
Okay, what are they?
Non-negotiable. Antivascular injury, needing repair, obviously. And the big one, if the radial nerve palsy happens after you try to reduce the fracture, post-reduction palsy.
So if you cause the palsy trying to line it up, bracing is out?
Correct. That's a major red flag. It means the nerve is likely getting trapped or stretched in the reduced position. You can't brace that.
Got it. Absolute. Vascular injury, post-reduction palsy. What about the relative ones? Maybe not.
Yeah, there's a few. Patient things first. If someone's very obese or has very large pendulous breasts, it's just hard to get a good fit and effective compression. And non-compliance, obviously.
Makes sense.
Then injury factors, segmental fractures too unstable, bilateral humerus fractures, a floating elbow, and you've got forearm fractures too, makes the whole limb unstable.
Hard to control.
Exactly. And significant displacement, that classic 20 degrees angulation, 20 degrees rotation, 2 centimeter shortening rule. Also, transverse fractures. They just don't have much surface area for stability compared to spiral or oblique ones, so bracing doesn't work as well. And, if the patient just has tons of pain that you can't control with the brace, something's probably not right.
It's interesting the notes specifically say open fractures aren't an absolute contraindication.
Right. Theoretically, after a good washout and debridement, if the soft tissues allow, you could consider bracing, but you'd be very, very careful.
Okay, so how well does bracing actually work? Outcomes.
Well, historically, Sarmiento's original paper, way back, showed amazing results, like only a 2% non-union rate in over 600 patients.
Wow, 2%. That sounds fantastic.
It did, and that really cemented bracing as a go-to treatment for a long time. But more recent evidence, like the FESH trial that was a proper randomized trial comparing bracing directly with plate fixation.
Okay, what did that find?
It found that, yeah, functional outcomes at a year were pretty similar between the groups, but the non-union risk with bracing was much higher than we thought.
How much higher?
25% non-union in the bracing group compared to only 8% in the plating group.
25%. That's a huge difference from 2%.
It is. It's a really significant finding and definitely shifts how you think about the risks versus benefits of bracing today. Something crucial to remember for exams that contrast between historical data and current RCT evidence.
Definitely. The notes also mention doing exercises in the brace. Why is that?
It ties back into that hydrostatic pressure mechanism. When the patient contracts their muscles, it actively helps compress the fracture site within the brace, maintaining reduction and hopefully stimulating healing. It's dynamic.
Using the body's own pump.
Sort of, yeah. And that's also why if someone has a brachial plexus injury, you wouldn't brace them.
Because the muscles aren't working.
Exactly. No functioning muscles, no hydrostatic compression. The brace just isn't going to be effective in the same way.
Right. Okay, so if bracing isn't the answer, surgery's on the table. Plating versus nailing. What's the thinking there?
Well, looking at the evidence, like at that Cochrane review from 2011, union rates seem pretty similar overall between plates and nails.
Oh, okay.
But nailing tends to come with more shoulder issues, pain, stiffness, and more often needs a second operation, just to take the nail out later.
But nails have perceived upsides, right? Like smaller scars?
Yeah, the common arguments for nailing are usually immediate weight bearing, which isn't always the case, but often permitted, and definitely a smaller wound compared to open plating, less soft tissue stripping.
And this seems critical. Nailing is generally a bad idea if the patient has a radial nerve palsy.
Absolutely. Big contraindication usually.
Yeah.
Passing that nail down the canal, potentially blind across the fracture site where the nerve might be, the risk of snagging or trapping the nerve is just too high.
And if you decided you needed to open it up to see the nerve anyway?
Then you've lost the whole minimally invasive benefit of the nail in the first place, haven't you? Might as well use a plate.
True. The notes also mention nail designs have improved, though, to try and reduce those shoulder problems.
Yeah, that's right. Older nails often went in quite laterally, right through the rotator cuff footprint. Bad news for the supraspinatus.
Ouch.
Newer designs often use a more medial entry point, trying to preserve that tendon insertion. And there's this technique of medializing the nail proximally.
Medializing, shifting it inwards within the bone.
Exactly. Positioning the top of the nail more towards the center of the humeral head. This does two things.
Yeah.
It leaves more bone on the outside. The lateral side, they call it a lateral bony bridge, which makes it stronger.
Okay.
And it also makes the whole construct better at resisting varus forces, that tendency for the humerus to angulate inwards, which is a common problem. So better stability.
Clever. Okay, let's pull this all together. How do we manage these common scenarios, especially with the nerve? Scenario 1, pre-reduction palsy. Patient comes in, fracture's there, wrist drop is there. Now what?
Right, this is key. Just because the nerve isn't working when they arrive, it does not automatically mean they need surgery on the fracture.
Oh, okay.
Expectant management waiting to see if the nerve recovers on its own is often the right call for the nerve itself. Spontaneous recovery rates are actually pretty high, especially for those Holstein-Lewis types. That Ekholm study showed like 89% complete recovery.
89%. So you operate based on the bone issues, not the nerve palsy.
Exactly. You decide on fixing the fracture based on the patient, their job, hand dominance, body shape, maybe compliance issues, and the fracture itself. Is it transverse? Is it badly displaced past that 20-22 centimeter guide? Is it very distal where muscles pull harder? Those are the reasons you'd fix the bone surgically.
And if you do decide to operate because of those factors and the nerve palsy is already there, what's the fixation method?
Well, like we said, nailing is generally out because of the nerve risk. So plate fixation is usually the way to go in this situation.
Yeah.
ORF.
Open reduction internal fixation. And the approach.
Has to be posterior. You need to see the radial nerve, identify it, protect it while you're putting the plate on. You absolutely have to visualize it and document where your screws are relative to where the nerve crosses.
Very important point. Just pausing here for a moment. Remember, this deep dive is drawing heavily on the Ortho-Made simple notes available over at mokyingren.sg. Really useful stuff.
Definitely worth checking out.
Okay, so nerve palsy was there before. You fixed the bone or decided to brace it. How do you monitor the nerve recovery now? The notes say there aren't strict rules.
Yeah, it's not like a set protocol everywhere.
Yeah.
Obviously, you monitor the bone healing with x-rays, looking for callus, bridging, clinical signs of union. For the nerve, it's mainly watching and waiting clinically.
Watching for what?
Signs of recovery. Specifically, you track tunnel sign. You tap gently along the nerve's path, starting near the fracture and moving distally. When the patient feels tingling or pins and needles at the spot you tap, that suggests the regenerating nerve fibers have reached that point.
Ah, so you can track its progress down the arm.
Exactly. See if it moves from, say, activating the ECRB muscle down towards the EIP muscle over weeks and months. That's a good sign.
What about tests, scans, electrical studies?
Ultrasound could be helpful, maybe around 3 weeks after the injury or surgery when the initial swelling goes down. Xiao suggested this. It can sometimes show if the nerve looks continuous or if there's a gap at the fracture site.
And if it shows a gap, discontinuity.
Then you're much more suspicious of a significant injury, maybe even a laceration, that might need surgical repair, like a nerve graft.
Okay. But if the ultrasound looks okay, nerve seems continuous, but clinically nothing's happening, then what?
Then you usually wait a bit longer, maybe around 3 months post-injury, and get formal nerve conduction studies, NCS and EMG electromyography.
And what do those tell you?
They're crucial for telling the difference between neuropraxia, where the nerve is just stunned, the axon is intact but not conducting properly, and axonotmesis, where the axon itself is damaged and undergoes Wallerian degeneration, even if the outer sheath is okay.
And knowing that difference changes what you do next.
Completely. If it's just neuropraxia, you generally keep monitoring. Recovery is expected, though it can be slow. But if the tests show axonotmesis, Wallerian degeneration, well, now time is ticking. Because the muscles the nerve supplies, their motor end plates, start to degenerate if they aren't reinnervated. You typically have a window, maybe up to 6 months from the injury, where direct nerve repair or grafting might work because those end plates are still viable.
And if you're past that window, say it's been 9 months or more,
then those motor end plates have likely given up. Direct nerve surgery probably won't restore function. At that point, your main option becomes a tendon transfer, using other working muscles to take over the jobs of the paralyzed ones, like restoring wrist and finger extension.
got it. A very clear pathway based on clinical signs, investigations, and crucially, timing. Okay, scenario 2. Post-reduction palsy. You line up the bone, maybe in the ED or theater, and then the wrist drops.
Right, this is different. This is an urgent situation, and like we said, an absolute no-no for bracing.
Well, that's the first step.
Immediately undo whatever reduction maneuver you just did. Take the fracture back out of that position and see if the nerve function comes back straight away.
And if it doesn't, or if you can't get the bone reasonably aligned without causing the palsy again.
Then that's an indication for surgery. You need to go in and fix it, usually with a plate, and explore the nerve at the same time to see why it's getting pinched or stretched during reduction. Something mechanical is happening.
So unlike the pre-reduction palsy where you might wait and see, post-reduction palsy needs immediate action to decompress that nerve.
Yes. It implies the nerve is being actively compromised by the fracture position or manipulation. You need to address that.
Okay, final scenario. Someone had a humeral fracture ages ago, maybe it was braced, maybe fixed, but they've been left with a chronic radial nerve palsy. Recovery just never happened. What can you offer them?
Again, it comes down to timing from the original injury. How long has it been? If it's still relatively early, say less than 6 months or so, and there are no signs of recovery, you might still be in the window for a nerve transfer.
Nerve transfer, not repair or graft.
Right. Nerve transfer involves sacrificing a less important nerve branch, maybe from the median or ulnar nerve, and rerouting it to power the key muscles supplied by the radial nerve. It can work if those motor end plates are still receptive.
Okay, so possible if it's under 6 months. What if it's much later? More than 9 months, maybe a year or more out?
By then, as we discussed, the motor end plates and the target muscles are probably too far gone for any nerve-based reconstruction to work. The muscles won't respond even if you get a nerve to them.
So then it's tendon transfers.
Exactly. That becomes the main salvage option. You reposition tendons from working muscles, often those powered by the median nerve, like wrist flexors to restore the lost functions, primarily wrist extension, finger extension, and thumb extension abduction.
So for chronic palsy, that time since injury is the critical factor dictating whether nerve surgery or tendon surgery is the better bet.
Absolutely. That timeline is everything.
This has been really clarifying. We've gone through the biomechanics, the prevalence of nerve issues, the pros and cons of bracing versus surgery.
Yeah, cover the Sarmiento brace mechanism, its contraindications, especially the absolute ones, and that crucial fish age trial data highlighting the non-union risk compared to plating.
And the differences between plating and nailing, particularly why nailing is usually avoided with nerve palsy, and the nuances of nail design.
Then we really drill down into managing the radial nerve based on when the palsy presents pre-reduction, post-reduction, or chronic, and the algorithm involving observation, ultrasound, NCSMG, and the timing for potential nerve or tendon surgery.
It really pulls together the key decision points you need for exams and for making good choices in practice. It's about understanding the why behind the protocols.
Exactly. Knowing why the fish trial matters, or why post-production palsy is an emergency, or how timing dictates salvage options for chronic palsy, that's the level of understanding you need.
So as a final thought for everyone listening, maybe reflect on how you synthesize all this. You've got patient factors, fracture specifics, nerve status, evolving evidence. How do you weigh it all up, especially when faced with that complexity of a nerve injury alongside the fracture? It's that integration that really marks clinical expertise.
It's definitely a balancing act, putting all those pieces together for each individual patient.
Well, thank you for joining us on this deep dive into humeral shaft fractures. And just one last time, this discussion was based on the excellent Ortho Made Simple notes found on the website mokyingren.sg.